Welcome back. As we begin our next session, I'd like to remind you that you can make a donation to EMSP directly from the conference platform. MS is often described as a young or middle-aged person's disease, but aging is actually a risk factor when it comes to developing progressive MS. Professor Xavier Montalban is joining us today to help us better understand aging and progressive MS. Professor Montalban is chair of the Department of Neurology-Neuroimmunology and director of the Multiple Sclerosis Centre of Catalonia at Vall Hebron University Hospital in Barcelona, as well as the chief of the Neuroimmunology Research Group at Vall Hebron Research Institute. Professor Montalban is also the former president and current honorary member of the Council of the European Committee for Treatment and Research in Multiple Sclerosis. He's been a member of the U.S. National MS Society Clinical Trials Committee and chair of the Medical and Scientific Board of the Multiple Sclerosis International Federation. Dr. Montalban is a board member of the European Charcot Foundation and of the International PROMS Initiative. He's authored over 500 original and revision publications in international peer-reviewed journals, plus several book chapters. And recently, he co-directed the development of the first ECTRIMS EAN multiple sclerosis treatment guidelines. After his presentation, we'll be taking your questions, so be sure to submit them as they come to mind. Now it's my pleasure to introduce Professor Xavier Montalban.
Good morning, everybody. Thank you very much, John, for this very nice introduction. It's my pleasure to stay here with you, so thank you very much to the organizers for inviting me to stay here and join your meeting. Let's see if I can
have a moment. Perhaps we can talk a little bit about the increased focus on the subject of aging in MS in general and progressive MS. It seems as the MS population ages itself, there's more of a research emphasis on understanding how aging impacts MS and how MS impacts aging.
My presentation has, in fact, two parts. One is living with MS once you are getting senior, let's say that way, which is not necessarily easy. And the other side is how age is impacting MS itself. And I think there are two different aspects here to be discussed. I wonder if you are not able to get my slides. Perhaps I can use my slides from here. And without you, let me just check, otherwise that would be a little bit, I apologize for this. So, okay, why we don't, are you able, the technical people, are you able to pass the slides while I'm saying number 2, number 3? Is that okay? Okay, so I'm now in my disclaimer slide, which is number 2. So I think this is a very important slide, number 2, with my disclaimers here. If we go to number 3, I don't know how many times have you read this definition today, but I think it is important. It's the definition of progressive multiple sclerosis. It's a multiple sclerosis course characterized by a steady increasing objectively documented neurological disability independent of relapses. So it's accumulation of disability independent of relapses. However, fluctuations, periods of stability, and suffering post-relapses may occur. We have two types of progressive MS, as you will know, secondary progressive and primary progressive, which means progressive phase from the very beginning with no suffering post-relapses. Primary progressive accounts for about 10 to 15% of patients with multiple sclerosis. This is number 4 slide. And they are typically older at onset, and the ratio woman to woman-man is 1:1, which is not like in relapsing forms of multiple sclerosis, which is 2, 3 to 4 even to 1. Typically, there is a prominent spinal cord involvement, which obviously impairs mobility. Secondary progressive MS, there is an estimation that 65% of individuals with relapsing remitting MS will develop SPMS within 20 years. But I have to say, and I would like to clarify this, this data is coming from very old cohorts, and nowadays the prognosis is much better, and I will show you as well a couple of slides on this. If we go to slide number 5, which is the 2013 Clinical Phenotypes Revision by Loveland and co-workers, we published this paper indicating that we have essentially relapsing MS and progressive MS. Progressive can have two different backgrounds, the primary progressive and the secondary progressive MS. And we have a number of modifiers which are really very important from the clinical point of view and from the practical point of view, which is activity, that means relapses and or new T2 lesions and or gadolinium-enhancing lesions, and progression of disability without relapses. So next slide is number 6. I think this is an animated slide, but if you go to the bottom part of the slide, this is a simplistic way of checking how many people with progressive MS do we have in the world. If we are 2.3 million people with MS worldwide, if 15% of those have a progressive disease from onset, if 70% with relapsing MS will develop progression at the end, it turns out that we have 1.3 million people with progressive MS. Probably this is a little bit too much, but depends how you look to the problem. Next slide, which is going to be number 7, is Aging with MS is the title of my presentation, but as I mentioned to John before, I would like also to talk about the impact of age on MS and its treatment. So the first thing is that you know that even in the university nowadays, we say that MS is often described as a disease of young and middle-aged adults. But about 30% of all people who are living with MS are over the age of 55 and 15% over 65. Why is that? Because longer life expectancies in the general population, plus improvements in the MS-specific care, which means better treatment of comorbidities and the introduction of DMDs, disease-modifying drugs, have contributed to longer average survival times for people with MS. And then if you go to slide number 9, is that the population is growing older, at least till we had the COVID. But this is the tendency. The global population older than 60 years is currently 1 billion. And people in their 80s are expected to triple by 2050. And the life expectancy has increased worldwide and is expected to continue increasing even in the developing regions. If you look to the right side of my slide, in red you have Africa. So Africa in the 50s, and now in 2020, as you can see here, the life expectancy has increased quite a lot. In Asia as well. So that means that MS prevalence is increasing. On one hand, probably the data is not really strong yet, but probably the incidence of MS is increasing as well, and we don't know the reasons for that. We can speculate, but we don't know the reasons for that. But the mortality is decreasing, and here you have examples from Europe and from Australia and New Zealand. So that means that if the incidence is increasing, the mortality is decreasing, the prevalence, the number of patients with MS is also increasing. On the other hand, peak mortality in MS patients is shifting towards elder age groups, as you can see here. This is the 1970, 1979 Here, the peak of mortality was in the 60 years. Now is 65, 69, and it's much lower. So this is one thing. So more MS patients, older patients, because of the decrease of mortality and probably an increase in incidence. Then we have the normal aging, because many of the symptoms experienced by people with MS, such as pain, fatigue, depression, cognitive changes, visual disturbances, and mobility losses, are also commonly experienced by people aging without MS. And in fact, older adults with MS over 65 years report greater activity limitations in the areas of bathing, dressing, toileting, getting out of bed, shopping, and getting around the community. And they also identify transportation, accessible housing, professional home care, social well-being programs, pharmaceutical services, nutrition programs, and physical wellness exercise programs as the most important services they needed to maintain their health and well-being. And this is not just for MS. I think this is for senior people in general. We have the biology of aging. We have a number of phenomena here. This is a slide. I don't know the number. I think it's number 14. It's number 14. The biology of aging, and we have a telomere attrition, genomic instability, a stem cell exhaustion, cellular senescence, etc. This is all these phenomena, all these mechanisms are normal in aging, but can be accelerated in neurodegenerative diseases such as Parkinson, Alzheimer's, and others, and perhaps in multiple sclerosis as well. This is a very useful journal I found, MS in Focus, in 2015. This is the normal aging processes. I'm in the following slide, of course. And then I identified a number of normal aging symptoms, and I wrote them here. So less muscle mass and strength, increased fatigue, constipation, weaker bladder problem or control, vision problems, short-term memory declines, slow cognitive function, and increased risk depression. As you can see here, many multiple sclerosis patients complain about all these symptoms, perhaps in a younger age. Next slide is the prevalence of comorbidities. The prevalence of comorbidities in people with MS is high and increases with age. This is a beautiful figure from the MS Brain Health and supported or coming from a paper by Ruth Amory. And as you can see here, depression and anxiety is more or less the same over time, while others comorbidities such as hypertension, hyperlipidemia, diabetes, and heart disease are increasing with age. And the problem is that patients with comorbidities reach, next slide, reach disability milestone sooner. And you have a number of, a graph here, a Kaplan-Meier on the left side, indicating that patients with vascular comorbidities, they get worse than patients without these comorbidities. So comorbidities, again, very important, and very important in general for everybody, but once you are getting older, if you have MS, if you have progressive MS, they are really key. Next slide, these are the results of the Aging with MS Online survey that the MSIF did in 2014. About 2,000 people from 70 different countries around the world took this survey about aging with MS. And as you can see here, one of the questions was, has your MS changed with age? And most of the patients said yes. A number of them said not really. I don't know what that means exactly. A very small proportion of them said no. And when we talk about main concerns about aging with multiple sclerosis, we realize that the main one is independence issues. This is on the right side, the blue bar. Independence issues. So everybody wants to be independent and they don't want to lose independence. Then the developing memory issues as well, requiring care at home or in a care home, and also, of course, economical problems. So I think this is a very useful information, not surprising at all. Next slide is about the people with MS above the age of 55. They are typically, we are always talking about typical cases, so typical population. They are more likely to have a secondary progressive form of MS, more likely to have a greater level of significant disabilities that require help from caregivers, more likely to be living without a partner, more likely to be unemployed or retired, less likely to be engaged in leisure or outdoor activities, and more likely to have cognitive problems and depression. So this is the data we have. In the next slide is aging an aggravating mechanistic factor for MS? This is another way of looking at the same problem. So what happens with patients with MS once they are getting older? And now is aging an aggravating mechanistic factor for MS? And in fact, epidemiological evidence indicates that age is the strongest predictor for the transition from the relapsing phase, which is, as you know, considered primarily inflammatory, to the secondary progressive phase of the disease, which is mainly neurodegenerative. And aging is one of the most important risk factors for the development of several neurodegenerative diseases, including progressive multiple sclerosis. It's very rare to see patients with Parkinson's disease, with Alzheimer's disease, young patients. It's possible, we see them, but very occasionally. But for progressive MS, we can say the same. We see patients, young patients with progressive MS, but we see progressive MS mainly in older patients. And it turns out that cellular senescence is a key biological process underlying aging. And in MS, accelerated cellular senescence may drive disease progression by a number of different mechanisms, and that you can see in this figure. I recommend to read this paper, which is very good indeed. So senescence of a number of different cells within the CNS, OPCs, mesenchymal cells, neurons, astrocytes, immunological cells, B cells, T cells, innate cells, microglia. They can produce inflammatory phenomena, neurodegeneration, remyelination failure, impaired recovery, and therefore, at the end, a clinical impact on disability progression. Next slide. This is important. So aging exhibits a great diversity of phenotypes. And all of us, we know that people with the same age, they can look completely different. And this is a complex phenomena and depends very much on the interaction between genetic and environmental factors. For genetic factors, we cannot do too much nowadays, but for environmental factors, we can do a lot. And we have to take care of a number of things that you know very well: exercise, vitamin D, all these things that you know very well. Next slide, please. So the question is, MS brain is older than healthy controls. And now we are talking as a group, and I have to say that probably it is. And this is a nice paper that I think has been presented this morning as well. It's going from the Magnims group and published recently in Annals of Neurology. They studied healthy controls here. Let me just go here. Healthy controls, the next slide, please. Healthy control CIS, which means patients with the first episode, suggestive of demyelinating disease, relapsing remitting patients, secondary progressive MS patients, and primary progressive MS patients. And they found that the brain age studied by machine learning is 6 years older in patients with multiple sclerosis than in healthy controls. As a group, of course, always as a group. And there are other data. This is coming from studies indicating that patients with progressive MS, as you can see here, can have telomere attrition, which is a sign of aging as well. And it's more important than in patients with relapsing remitting MS or in controls. Next slide, please. So these findings support the idea of MS as a disease of aging, even though the MS patient population is not what we would typically consider an age population. But age is becoming a clear role in the development and in the prognosis of multiple sclerosis. Next slide. That means that strategies for the potential future need can help people with MS and their families to stay on top of whatever may come. Although we have a number of things to do, but still we have to be careful with the future. Next slide. What about the characteristics of MS in later age? Well, it's a little bit different. So now we have 4% of our MS population has a late onset multiple sclerosis. And in fact, very late onset multiple sclerosis can be seen in 0.5% of MS patients. Next slide, please. And this is a positive finding. Relapse rate is reduced with advancing age, and in the graph on your right side, you can see this is the mean number of relapses during the relapsing remitting phase, and it's going down over the years. So this is a positive phenomena, and if we go to the next slide, please, you can see on the right side again the gadolinium enhancing, which is age dependent. In the y-axis, you have the percentage of scans with gadolinium enhancement, and down there on the x-axis you have the age. You can see that when you are 30, 45% of patients will have gadolinium enhancement lesions, while if you are above 60, only 10% of them will have gadolinium enhancement lesions. Next slide, please. The negative side of this is that if you have relapses once you are senior, relapses are less likely to recover completely. And so we have to be careful with that, and we don't want people with a certain age having relapses. Next slide, please. Well, this is I'm going to skip that one and go to number, let me just check which slide is that one. Can you go to slide number 36, that you can read treatment in elder MS patients. So the evidence of efficacy of DMTs in the elder is scarce for a number of reasons. The first one is that older patients are usually excluded from randomized clinical trials. They typically have comorbidities, and I have a slide on that. And also, pre-specified subgroup analyses have been rarely performed in clinical trials, so we don't have too much information about that. But in general, we can say that subgroup analyses, many of them post hoc, have shown poor response to DMTs in patients older than 40, 55, even older than 40. And this is common for many, many drugs. Probably you can't read anything here, but there are a number of trials in this slide. And also, and as I mentioned before, comorbidities are not adequately addressed in randomized clinical trials. Let me just skip this one, the treatment in elder MS patients, and go to the one that you can read faces and phenotypes of multiple sclerosis with a number of colors on it. So if we are in the right slide, this is the impact of age on disability worsening outcome in multiple sclerosis clinical trials. And this is inhibition of disability worsening on the y-axis, and you have age in the x-axis. And as you can see here, once you are getting old, the benefit on disability is less than if you are, sorry about this, if you are younger. Next slide. but not everything is negative. Again, this is the data coming from the clinical cohorts, one from Lyon and Vancouver and London, Ontario. So here you have the median time from onset to EDSS 6, and at the end, more than 50% of patients in the clinical cohort will develop or developed a severe disability after 20-25 years. But now this is different. In 2013, these authors reported that 38% of patients with relapsing remitting MS patients from Olmsted County remained in this phase, so they didn't convert to SPMS when they were 75 years or older. Next slide. And this is it's an animated slide, I'm sorry about that. This is the long-term evolution of multiple sclerosis. If you can push a few times. So we have here two single center studies. One is the EPIC cohort coming from UCSF, more than 500 patients. You realize that patient reaching EDSS 6 at 10 years is 4.7. And at 20 years is 16.2% of the patients. So a very small proportion of patients nowadays reach an EDSS of 6 after 10 or 20 years. And if you continue, and then you have the Barcelona cohort, I'm not sure what you are seeing, but the Barcelona cohort, if we just take only those with more than 10 lesions in the brain, in the baseline brain MRI, only 7% of patients after 10 years will reach an EDSS of 6, and after 15 years, only 9%. So the disease has changed quite a lot, and this is very positive. We can mention the reasons why this is happening later on. Could you please go to the last slide, which are the remarks? I would say that the prevalence of aging individuals with multiple sclerosis is increasing worldwide. Aging people with MS present with unique challenges, including a high burden of comorbidities and an altered immune system profile. Data on the safety and efficacy of current disease-modifying therapy in elderly patients with MS are lacking, indicating the need for further studies in this specific population. A substantial proportion of elderly patients with a stable MS will need to consider whether to discontinue disease-modifying therapy, but we don't have enough data to suggest that or to advise for that. Complementary lifestyle modifications, and I think this is really key, that promote wellness and cognition can help aging patients with MS to manage their comorbidities and improve their quality of life. This is true for everybody, but for MS patients even more. And then a multidisciplinary approach toward care of elderly patients or persons with MS is required, including physical therapists, urologists, orthopedic and geriatric specialists. And the next slide is a picture. It's an old picture already, but I just want to highlight the help I had from Dr. Simone Cardenas, who is an ECTRIMS fellow from Colombia, who is spending 1.5 years in our center now, from Martin Torre as well, and from Alec Rivera. And I thank you very much for your attention. Thank you.
Well, thank you very much, Professor Montalban. I'd like to get to. Early in your presentation, you mentioned the percentage of people with relapsing remitting MS who transition to progressive MS. And someone has asked, will newer therapies, the higher efficacy therapies, reduce the percentage of people with relapsing remitting MS who end up transitioning to progressive MS?
Yeah, I think, can you hear me, John?
Yes.
Can you hear me? Okay.
Yes.
So I think this is a very, very important question. And I think the academic right answer would be we don't have still strong evidence for that. But I think everything is pointing that this is the case. So we are modifying the natural history of multiple sclerosis. We just recently reviewed our CIS population, more than 1,400 patients with CIS, followed since 95. And it is clear that the disease is completely different. And if you divide the patients in different epochs, you realize that the recent epochs, they are doing much better. So I think that the answer for that is yes. I think we are decreasing the percentage of patients who are transitioning to SPMS with high efficacious drug and perhaps first-line drugs as well.
We have a second question. Someone asked, are disease-modifying therapies given to people over the age of 55? And I'd like to add a second part to that myself, and that is, are disease-modifying therapies shown to be effective for people over the age of 60 or so?
Well, as always, it's very difficult and very risky to give one simple answer to that. We have seen patients with 65, 68, 70 years with a very active disease, with quite a lot of inflammatory activity in the brain MRI or in the spinal cord MRI, which is not the typical thing, but we have seen those. So I would say that for that specific population, the disease-modifying drugs, in fact, the highly efficacious drug, they do work quite well. If you're saying, well, if we have a patient with a progressive phase, not very rapidly progressive, 68 years, 70 years, would you recommend any treatment? Probably, I would say, okay, I will be very cautious here. And remember as well, we are in the COVID time. So I think this is case by case. But once you are getting older, DMD has to be considered very carefully.
Thank you. Final question that we have time for right now. Someone is asking, what is the impact of the loss of brain volume as people with MS age, specifically the impact on cognitive function?
Right. So as everybody knows, we are people without MS. We are losing brain over time, men more than women, and but luckily we increase the connections between neurons, and that seems to be a good compensatory mechanism. Of course, there is a correlation between brain atrophy and cognitive involvement in the long term in patients with multiple sclerosis, and also there is a correlation between brain atrophy and disability, physical disability, in the long term in patients with multiple sclerosis. So we want to preserve as much as possible the brain tissue in our patients with multiple sclerosis, of course.
Well, thank you again, Professor Montalban, for sharing that information with us.
Thank you very much, John. Thank you very much, everybody.